Good morning, good afternoon, and welcome to this second part of this two-part webinar series on advancing neonatal nursing education in Africa. Many thanks to today's panelists for this partnership between Project Hope, the Council of International Neonatal Nurses, or COIN, and the Ministry of Health and Sanitation of Sierra Leone, also last week with USAID and WHO, in bringing this webinar to you in recognition of 2020 being the year of nurse midwives around the world. My name is Tom Kenyon. I'm the Chief Health Officer at Project Hope, and it's my privilege to serve today as moderator. Just a reminder that you can submit questions at the bottom of your screen through the chat feature, and we'll do our best to address all of those at the end of today's session. Today, in part two, we are fortunate to have four highly experienced professional educators who will cover current models of neonatal nursing education in Africa and lessons being learned in the process. Again, we're focusing on Africa, not just because it has one of the most challenging workforce situations, but because while accounting for 17% of the world's population, it has 38% of global neonatal deaths. And we covered some of that last week in part one on the overview of neonatal nursing education and the need for this and potential approaches. Today, we're discussing some real country situations. So in part one, we provided this overview of neonatal nursing education in Africa, why it's needed, and potential approaches. We heard from global leaders on newborn nursing education from USAID, WHO, COIN, and Project Hope. They added to our understanding of why now, when it comes to training a new cadre of nurses to care for sick and low birth weight newborns, this being a relatively new concept among African countries, and something where we can all learn from each other to help lower unacceptably high rates of newborn mortality. So in part two, we're going to discuss emerging models, addressing challenges, how can we increase global support, and most importantly, how can we share experiences as we roll out this relatively new training program. So let's begin with part two, a comparison of different models of neonatal nursing education and sharing implementation lessons. So this is our overview for part two. Again, several models of nursing education in different countries, and very importantly, the aspect of faculty preparation and curriculum development. And we'll close with recommendations at the end, but we look forward to your input into those as well. So we have really four terrific presenters today from COIN. We have Dr. Sue Privilege. I'll introduce each speaker at the beginning of their session. From the Ministry of Health and Sanitation in Sierra Leone, we have Professor Samai, the Director of Research and Training. He's also the Deputy Vice Chancellor at the College of Medical Education and Health Sciences, Dr. Puma from Project Hope, and Dr. Kruger, also from Project Hope. So our first presentation will summarize current models of neonatal nursing education in Africa. And we're pleased to have Sue Privilege, who's a board member of the Council of International Neonatal Nurses. She's also a practicing neonatal nurse practitioner in a level 3 NICU in the United States. She's been very involved as an instructor in the MSc of Nursing level program in Rwanda on neonatal nursing, and she's provided technical assistance to Burundi, Sierra Leone, and Zambia. So Sue, over to you.
So good morning. So I was tasked with looking at neonatal education across Africa, And I know that there's a lot of things going on in Africa that I wasn't able to find, but I looked through Google and I had 3 different criteria to search by. I searched by the Neonatal Education, I searched by the Neonatal Council, and I searched by the university. So I looked, and if it pulled up the education, I would look and see what that was. If it nursing councils, I went to them because they accreditate programs and schools. And each university, I looked at their bachelor's and their master's programs to see if there was anything related to neonatology. Next slide, please. So on the next slide, so next slide is related to the postgraduate diploma. Kenya had, when I say postgraduate diploma, I mean advanced diplomas. So Kenya had at least five postgraduate diplomas. They had a post-bachelor's and a 1 year in length. South Africa had 3 programs that I could find, and it was midwifery with a neonatal combination. Ethiopia had 1 program that was postgraduate in maternity and neonatal nursing. Liberia had 1 advanced diploma in midwifery and neonatology, and Mr. Kola, who's probably on this call, helps run that program. And what was found there was they needed midwives to train them to do C-sections, and with that, more babies were being saved, so they added neonatology. This program is over a 1 year of length. I think it's up to 18 months, and there's a heavy UK involvement. They do lots of teaching from the UK. Zambia is trying to start an advanced diploma in neonatology. It's 1 year in length. They haven't started yet. It was started by a neonatologist out of Lusaka, with input from the UK and from the United States. Next slide. So then I looked at the bachelor's in nursing. Malawi, which is part of Project Hope, looked to start a master's program, but decided that when they looked back at the bachelor's program, they realized it wasn't well grounded in neonatology. So they decided to back it up and do a bachelor's in neonatology to give the students well-rounding in neonatal nursing, and then they were going to start their master's program. Ethiopia has a bachelor's in neonatal nursing. I was unable to see the curriculum for much of this stuff, so I have no idea what they're teaching within their courses. And Morocco had a bachelor's in nursing with an option in specialization of neonatology. Next slide. So then with masters, there were several things I found. South Africa had 2 programs, maybe have more, I don't know. But they had advanced midwifery and neonatal science and an advanced midwifery with maternal, child, and women's health, combining all 3 of those things with some neonatal courses. I know that Ethiopia has, with a university from the States, sending over mentors and nurse practitioners, just graduated their first cohort of MS in advanced neonatal practice. So it's a heavy U.S. involvement, sending mentors of nurse practitioners and teachers. Now, Rwanda has an MS in neonatal health, which was started in 2015. I sat on the curriculum development, and I taught in the first cohort, and I am back teaching in the 3rd cohort. The exciting thing about Rwanda is, and something if you're going to start any of these programs, is they've just now come up with the scope of practice for master's students, which we'll call them advanced nurses. And it is heavy on the nurse practitioner side, so we'll have to adjust our program to make sure that will be able to call themselves nurse practitioners. Angola has a master's in obstetrics and nursing and neonatal science. Botswana has a master's in nursing, which has 6 credits, or just 2 courses in neonatology. So the next slide. So what I mean other is I couldn't find a lot of information, but there was some information. When I pulled up Ghana, it said it had a neonatology residency where you had to have a bachelor's to get into this residency. It was 3 years in length. It offered an exam at the end, but it didn't designate what title or how they functioned when they graduated. Tanzania had on-the-job training, which means the training was created for nurses and midwives that are already working in the neonatal units. It was 9 weeks in length. Cameroon had a few weeks, 1 to 2 weeks on-the-job training. Namibia had a few weeks of on-the-job training, which it was created by a neonatologist. Burkina Faso had on-the-job training created by Kiesi, who started a neonatal unit in the capital, and they trained all their nurses to work there. Egypt, the only reason I mention this, it's hard to define what they were doing there because since I don't read or speak Arabic, but I know from experience that Case Western is offering a DNP program there, which is a doctorate in nursing practice. That's my degree, and it's a practice degree similar to a PhD, and I specialize down to neonatology. Zimbabwe, when I pulled them up, they had a neonatal curriculum for medical students that was under exam, but when I looked at it, it was heavy on delivery and immediate post-delivery time, but not a lot about the ongoing care that needs to be done with these babies in these neonatal units. Next slide. So the countries that had no information, I received, when I put in neonatal education, I would often receive midwifery information or information about neonatal resuscitation, not any ongoing education. And 23 countries on all 3 search words, neonatal education, universities, nursing councils, I was unable to find anything about what they were doing in that country related to neonatology. Next slide. South Africa, the only reason I mention this is because they did list their standards on the Nursing Council website, and it's the standards for their bachelors and the midwives. And I looked at that standard for neonatal concept. They had 2 references. Both of those were under quality of midwifery nursing care and to provide quality, safe and quality midwifery and nursing care. The only statement that really related to neonates under those 2 references was to recognize, to identify, to manage, and to refer. Nothing about the ongoing care of neonates in neonatal intensive care. Last slide. So the takeaway, and I know I've been speaking very fast and I'm sorry, is there is a patchwork of neonatal education across Africa. There's advanced diplomas, there's on-the-job training, there's bachelors, a few bachelors, there's a few masters. All of them are created in the country context and are often created by people that see a need, but there's no competencies at each of these levels. So each country is doing its own teaching. Most of the advanced diplomas were linked with midwifery, except for Kenya that had a 1-year linked program to meet their immediate needs. And I can say when you mix it with midwifery and neonatal and you expect it to be done in 1 year of length, that's a lot of information for the students who are coming in as general BSN nurses. By any means, they will at least learn some terms with neonatology, but they're not going to be proficient or expert in taking care of neonates in the level 3 nursery. Most neonatal bachelor's degrees in South Africa were linked with midwifery, and in Sierra Leone, the new model, it'll be linked with pediatrics, as you'll hear coming up. Standalone programs, there was only one in Ethiopia and the emerging one in Malawi. Advocacy is needed for standalone neonatal programs with specialization. As we heard from Dr. Arnella on the last webinar from the Neonatal Nurse Roadmap, we have found that there needs to be specialization in taking care of neonates at the bachelor's and the master's level. And right now, we've got a lot of different things happening. So it would be good if we had consistency across all programs and all cadres of Africa. And the COIN, the Council of International Neonatal Nurses, the competencies that we put together speak from, as Dr. Kenner said, from the novice nurse, the one that has never really been experienced, all the way to the expert. So this can be used to guide curriculum. This can be used to guide orientation processes in the units. It is a really good way to try and bring consistency in the education for the neonatal patients. But as you can see, after examining this, there's a deep need for quality advanced neonatal care for the sick and small baby. And I'll just end with this last caveat for the physicians and the neonatologists online. You know, we can train the nurses to be specialists, but we also need the doctors who are often general nurse doctors trying to take care of neonates, or they may be pediatric doctors, but they have, at least in Rwanda, they only rotate through the neonatal unit 3 times in their whole career. They can't be experts in the field either. We need to move this forward in the medical community and in the nursing community. And that's all I have. Thank you.
Thank you so much, Sue, and thanks for that overview of what's going on. I hadn't realized that there is a lot going on, but as you pointed out, there's tremendous variation between countries, and some is advanced and some is more doing what they probably should have been doing all along in a routine educational setting. And you made the point, and others made the point last week, including WHO, the need for these specialized nurses really to help lead the charge. And as you pointed out, and your colleague Carol Kenner from CEO of COIN, this needs to be competency based. When you have a sick newborn, it's the competency of the health worker that matters, not necessarily their degree or training. But we're only going to attract people into this profession if it offers some professional advancement as well. At least that's been my experience. Anyhow, our next speaker is Professor Mohammed Samai, who's the Director of Research and Training in the Ministry of Health and Sanitation in Sierra Leone. He wears many hats. He's also the Deputy Vice Chancellor at the College of Medicine and Health Sciences, or COMAS, and it's been a real pleasure to work with Professor Samai on this project, and his leadership has been terrific.
Thank you very much. Good morning, good afternoon. I will just share the Neonatal Nursing Education model in Sierra Leone and how we got to that point, the rationale that we built the current model on, and then maybe share with you some experiences in terms of the curriculum development and faculty preparation, and then some lessons learned from the whole exercise. Next slide. As you can see from this slide, it's just the neonatal mortality. So the target for now up to 2022 is to reduce the mortality to about 22. That will be like a 3% reduction in mortality between 2010 and 15. But then if we really took some action, we may be able to reduce it even further to 12. As you can see, this is from the Sierra Leone every newborn action plan 2017 to 2030, published in May 2017. Next slide. Yeah, the government before now has taken action really to establish special baby care units in and around the major districts in Sierra Leone. 4 were established in 2017. Additional 2 was established in 2020, and there is work in progress to establish 9 in almost all the district hospitals in the country. So that is work in progress. And hopefully those facilities will be up to speed by the end of the year. Next slide. Well, I need to give you a background of the cadre of nurses that do provide services in these special baby care units. As you can see, we have a total of 184 nurses really providing neonatal services at these facilities. 77% of these nurses are really state-enrolled community health nurses. These are state-enrolled community health nurses. These are really auxiliary nurses. They are not registered nurses. So we just have about slightly above 20% are state-registered nurses. And our target really is to produce more state-registered nurses and train them at higher level to be able to provide services at this special baby care unit. But in the interim, we still are using state-enrolled nurses, and we think we should, by default, improve their capacity in terms of the provision of neonatal services. Next slide. Well, currently, these are the major nursing programs that we do. The state-enrolled program is being run by the universities. So the universities train SRNs, these are the registered nurses. They offer them diploma, and then following that, they do a state board exam, and they are licensed by the Nurses and Midwives Board. That will give them the license to practice. Yeah, and we also have another cadre, which is an auxiliary cadre, the state-enrolled community health nurses. They qualify from the system with certificate in nursing. And we have a lot of institutions which were involved in this training. But for now, the Nurses Board have put an hold on this training because we have a lot of them in circulation. So as a country, we want to go back to the drawing board and see how we can convert some of these nurses to RNs or to some other disciplines. And then after the registered training, a good number of the registered nurses are enrolled in midwifery schools, and they do a post-diploma, post-basic diploma in midwifery. This is a course that is offered for 18 months, and they qualify with a diploma in midwifery, and they train and they practice as midwives, following their nursing training. And then those who have done the SCCHNs also have the opportunity for career development to be trained as community midwives, and they do a post-basic certificate in midwifery, and they are deployed in the community to provide midwifery services in the community. And very recently, we started the BSc Honors in Nursing, the BSN, and we have different tracks. We have those who will graduate with BSc General Nursing, those who will graduate with the midwifery degree. Some will graduate with BSc Nursing or Midwifery Education. And this year, we'll be able to introduce also a BSc in Pediatric and Neonatal Nursing. Next slide. Now, given the poor indicators, the infant and maternal mortality, and the fact that neonatal mortality contributes significantly to the infant mortality, as I said before, the country took steps to establish this special baby care unit to be able to reduce some of these indicators. And as by stroke of luck, Project Hope also came to the country to assist with neonatal education. So when Project Hope really came with the concept of neonatal education, it was discussed almost at the highest level, at the ministerial level, and that was even taken to cabinet for further discussion. So we had a lot of stakeholder meeting to be able to determine what exactly as a nation do we need to embark on in terms of neonatal training. And don't forget, I've told you before that 75% at least of the nurses providing neonatal services at the neonatal units, the special baby care units, are auxiliary nurses. So we have very few registered nurses involved in neonatal, the provision of neonatal services. So initially we thought we should do a master's program in the neonatal nursing. We actually went through the strains of developing a curriculum for masters in pediatric nursing and neonatal nursing. But then we realized at the end that we really do not have nurses with enough neonatal background, at least at the bachelor's level, to be able to enroll on this program. So if we are going to train people at master's level, and we are going to admit them from the cohort of nurses that we have, then we may have to spend a longer time doing the masters. And therefore, we decided that what we can do at this stage, we may want to go back to the bachelor's level and prepare a cohort of nurses or give them opportunity to enroll in the pediatric and neonatal program at BSc level. So once we have a cohort at this level, some of them may opt for the master's program in pediatric nursing, and some may opt for the master's program in neonatal nursing. So after a lot of deliberation, we agreed that we should do the BSN for pediatric and neonatal nursing, and then a master's in pediatric nursing and a master's in neonatal nursing. And again, what is not shown on this slide is that we have the Sierra Leone College of Nursing, which is really an institution established by Act of Parliament to train nurses at fellowship level. And the minimum entry requirement into that college is a BSc. So again, once we have people with BSc in pediatric and neonatal nursing, nothing stops us in the future to developing a fellowship and program for neonatal nursing in the Sierra Leone Postgraduate School of Nursing. So that is something that we'll look at in the near future. And then the stakeholders were also mindful that we needed to be politically correct, because the politicians will pay very little attention to these high-flying degree people. They actually want people who can produce the hands-on job at the facilities. And we have these SCCHS, these state-enrolled community health nurses, about 75% of them providing services at that level. So we went back to the drawing board together with Project Hope and UNICEF to develop a certificate program for those who are SCCHNs, and we're going to start with those who are currently working in the facilities. And the program has been designed so that it will not disrupt their normal operations. Next slide. These slides are actually has been presented already, because it's a slide that speaks to the previous slide in terms of why we had to develop a post-basic certificate program for the state-enrolled community health nurses, so that they can continue to provide service and improve their capacity and also improve their skills and knowledge in neonatal nursing. And the BSc program also, which will transition later into a master's program. Next slide. Now, what are some of the lessons learned and the recommendations? Now, as I said earlier, the introduction of neonatal nursing education was a very big topic with the ministry and the university and a lot of other stakeholders and NGOs involved in nursing education and nursing services. So we agreed that given our circumstance, we cannot just start the postgraduate. We needed to increase the competence of our RNs at BSN level before they can enroll on the postgraduate program. And also we have to also innovate because we have existing programs for which SCCHNs or the state enrolled community health nurses are trained with a postgraduate certificate in midwifery, and they serve as midwives. So why not do the same so that they can continue to provide quality neonatal services in these facilities? And then we had to collaborate. For all of this is not one institution business. We did all of this with very good and strong collaboration between the Ministry of Health, the university, specifically the College of Medicine and Allied Health Sciences, Project Hope, and UNICEF. And again, and in all of this, we needed to train faculty because it's good to introduce the programs, but if you don't have faculty to teach or to run with the program, then there is no work done. And we didn't want to rely on faculty coming from abroad at all times. So we have to agree with Project Hope to train faculty to be able to run with the program. So that is ongoing. And over and above that, mentorship has also been found to be very effective. So Project Hope, as we speak, has a very strong mentorship program where our faculties are being mentored to be able to carry on with the training. And where necessary, they will still interface with the students. And also, we needed the curriculum for which Project Hope and UNICEF and all the other players contributed to. Next slide. Thank you very much. That's the final slide.
Thank you, Dr. Samai, and thank you also for pointing out the importance of leadership. I mean, the head of state of Sierra Leone visited the Kangaroo Mother Care Center. The First Lady of Sierra Leone visited us when she came to the UN on this very topic. So I think Sierra Leone's been a terrific example of the highest leadership in advancing newborn health. And then, of course, with your leadership as a clinician, a former department director, dean of the medical faculty, and now the deputy vice chancellor, you've been so helpful in navigating us through an otherwise very complex process, and your commitment to the health workforce is really going to help Sierra Leone advance some of its health statistics. So thank you for your leadership.
Thank you.
Our next topic is around faculty preparation. This reflects on the ongoing experience with Malawi and Sierra Leone, and this will be presented by Dr. Elemis Puma from Project Hope. She's a regional neonatal nursing education fellow. And Elemis has been working with Sierra Leone and Malawi for a couple of years now to advance this process. She's an experienced nursing educator herself and has obtained her PhD in neonatal nursing education from the University of Cape Town in South Africa. So over to you, Elemis, for sharing your experience with faculty development. Hi, Elemis, are you there? Can you hear me?
Yes, I can hear you, and I had already started speaking. Sorry, I was unmuted. Good morning and good afternoon. The following presentation will focus on the faculty and mentorship preparation that Project Hope is coordinating, running in the two countries, Malawi and Sierra Leone, and the adaptations that we have currently carried on with this pandemic. Next slide, Eden. Next slide. So as the two presenters had already highlighted on the Neonatal Nursing Education program, Project Hope is supporting curriculum development as well as course development in the two countries, Sierra Leone and Malawi, which will focus on the neonatal nursing education for nurses and midwives. So this program focuses on training these nurses to enable them provide competent and skilled care for both sick and premature newborn babies. And the program is being run in collaboration with the COIN, Council of International Neonatal Nurses, and other academic institutions. For instance, we have Jefferson College of Nursing, which is supporting the curriculum development for both Sierra Leone and Malawi. The content that is being included in these two curricula includes content on care of the sick and preterm newborns, and it's based on the international guidelines on care of the sick and newborns, particularly WHO as well as COIN. Next slide. The faculty preparation, therefore, which is currently in progress for both Malawi and Sierra Leone, aims to equip these faculty members with skills and knowledge on what content needs to be included in the curricula, as well as how they are going to approach in teaching the candidates that will be recruited in this program. So far, the two countries have established curriculum development committees who are working on developing the curricula and course content, and they have also identified dignified or designated faculty members who will be responsible for delivery of the course content in the program. And these faculty are the ones who are undergoing the preparation and mentorship, as alluded by Professor Mai. So both programs are using various global resources. For instance, we have the American Academy of Pediatrics, HPB series. We also have the WHO and USAID guidelines on care of the sick, newborn, and premature newborn babies. And this is aiming at imparting the faculty with knowledge and skills in preparation for the program. Next slide. The program will equip the faculty members and preceptors with knowledge and skills, as already indicated, and it is including evidence-based interventions and clinical competencies in both theory and clinical practice. The target is the faculty members who have been identified in both countries to teach the students, and also clinical preceptors. And the clinical preceptors are registered nurses who are already working in the neonatal nursing units. And these will be also involved in teaching the students and supporting the students in the clinical setting. Next slide. So the faculty mentorship is being offered in 3 phases, focusing on the WHO level 1, level 2, and level 3 of neonatal care skills to increase knowledge and skill development. Both the faculty and clinical preceptors are undergoing this mentorship in newborn care, ranging from HBB to care of the sick and preterm newborns, including other important skills. For instance, care of newborn babies who are seeking intensive care. So trainers in this program or the clinical mentors have neonatal nurse specialists who are drawn from different institutions, particularly in the USA. And the program covers theoretical content and skills practice, and participants are undergoing skills checkoffs in simulation laboratories or skills laboratories before clinical practice in labor and delivery. Next slide. For the preceptorship, we have the two countries have identified preceptors, registered nurses who are working in the different health facilities in the countries, particularly in neonatal care units. So these preceptors will work in collaboration with the faculty to teach the students in the clinical settings. And the clinical preceptors will play a crucial role in improving neonatal care, considering that the students during the course of the neonatal nursing education program, they'll have to spend a good percentage of their time in the clinical settings. So these preceptors will be supporting the students to acquire the clinical competences that are required in this field. Next slide. As indicated, the participating countries are Sierra Leone and Malawi, where the NNE program is running. And Sierra Leone has already completed the phase 1 of the clinical preceptorship and mentorship, whereby during the phase 1, we had trainers from the US who assisted in both theory and clinical practice. And we included both preceptors and faculty members. And this team, particularly the faculty members, are undergoing phase 2 of the mentorship program. Whereas in Malawi, they are undergoing phase 1, which started last month. Together, we have 17 participants who are being mentored through this program, and 12 are from Malawi, while 5 are from Sierra Leone. And these 17 are the participants who are currently in training for this mentorship program. Of these, we also have 7 clinical preceptors, 2 from Malawi, and then 5 from Sierra Leone. Next slide. During this pandemic, it has been a bit challenging to have face-to-face mentorship. As a result, we have adopted an online mentorship program to implement the activities that include the faculty preparation itself. So for this online program, faculty members from Malawi and Sierra Leone have been provided with guided self-learning materials, reading video resources, including access to American Academy of Pediatrics Perinatal Continuing Education Program electronic books, which they are using as resource materials, and other resources. And every week, Tuesdays, we have seminars with topical presentations, and these are facilitated by a neonatal nurse specialist. And we include case studies for the participants, question and answer sessions, and periodic knowledge testing. Next slide. For clinical practice, we have considered clinical practice and adopted another approach as well compared to what was planned earlier on. And in this new approach, the faculty members are undergoing skills training, and in this skills training, we are using local facilitators and local resources. For instance, Sierra Leone just finished their skills training on HBB last week, whereas Malawi are having their skills training this week. And the faculty are being supported to practice the neonatal nursing skills through demonstrations, written demonstrations, and skills checkoffs. The program is running smoothly online and including the skills training, it's enabling the participants to acquire the required skills and competency. So far, we have seen active participation from all the participants in the 2 countries, in both the skills training and the online seminars that we are having, including completion of the tests that are being provided to the participants. Next, this should be my last slide. Thank you.
Thank you, Elemis, for that overview of at least a couple of countries that are going about neonatal nursing education. Again, in different ways based on the local context, and then how we've had to adapt during COVID-19, and that is probably going to be an approach going forward. Hopefully it'll be resolved someday, not too far from now, but we've all had to adapt, and your approach seems to be working. I'm sure we'll hear more about that in the upcoming Q&A. Our final presenter will be Dr. Carolyn Kruger, who's the Senior Nursing Advisor for Education at Project Hope. And she's going to summarize some emerging lessons learned from these neonatal nursing education models. Dr. Kruger is a very experienced nursing educator, has been a dean of a nursing school. She's had decades of experience with various nursing education programs around the world. And she's been working on this issue of neonatal nursing education for the past several years at Project Hope. So over to you, Carolyn.
Thank you, Dr. Kenyon, and welcome everyone. This is a summary of the first webinar and today's webinar, and trying to capture the lessons learned and also relating that to some emerging recommendations from this that we hope will be helpful to those of you that are thinking about developing a neonatal nurse cadre in your countries. The first slide is really working with how important it is to work with government and stakeholder commitment. Could I have the next slide, please? We have worked with both governments in Malawi and Sierra Leone for about 2 years, and their buy-in is really, really important in terms of making decisions, just going from awareness to making decisions. And that takes time, and everyone needs to be involved in that. If we have the next slide, it gives some of that information. So, and continuing, it took the form of national committees and workshops and forums, and a series of them over time, professional organizations and Ministry of Health accreditation, human resources in the ministry, and key stakeholders and NGOs that could provide support and sustainability. Once the decisions were made, then we had buy-in from all leaders of the country in terms of what is the best plan for the individual countries. Also, the collaboration between the health facilities and teaching institutions was exemplified in Sierra Leone with Dr. Samai. He had positions in both Ministry of Health and in Comas, the University of Sierra Leone, and he worked with both, but not all countries have that. So the counterparts between the ministry and the educational institutions are really needed to build a plan that meets the need for quality service providers as well as educators and a capacity of the students. We found that national HR, human resource planning, often did not have a neonatal specialty as a cadre. And so there was advocacy to include them in their planning because it is a new cadre and a new concept to decrease neonatal mortality, it wasn't always in the skills mix in the National Human Resource Plan. So that needed to be included and standardized. Next slide, please. In service, then, we've heard from our previous speakers that as we realized that there was a need for neonatal nursing skill development and knowledge development, there was an immediate need about what we're going to do now, because it takes time to educate advanced neonatal nurses in a college or a higher education institution. So as you heard in Sierra Leone with Dr. Samai, that they re-looked at that and said, what can we do in pre-service and in service to build the quality of the pre-service programs in neonatal nursing preparation, but also an immediate certificate program for those nurses who are currently working in special care baby units and kangaroo mother care units that to meet their need to have additional education so that they could practice immediately. And so that occurred simultaneously with the planning for advanced education for neonatal nurses. We also found that there was a lot of rotation of nurses who had neonatal skills that are essential, but they were rotating to other inpatient care settings. And so we encouraged that nurses who had neonatal skills, any experience, would stay in those units, and that helped to improve the quality of care. Pre-service education needed when we did the assessment, needed an emphasis on the care of small and premature babies, not just at the time of birth, but during the transition period and immediately after, and especially if the baby was needed resuscitation and had medical problems. And so the pre-service education had to strengthen their curriculum and also their faculty to be able to teach that and include that in their curriculum. So curriculum development was difficult, we found, over the last 2 years because it has new concepts, it has new skills, state-of-the-art, evidence-based, and curriculum development then it was hard to develop because there needed to be faculty designated to teach it that also knew those skills and also knew the knowledge that would make them capable of teaching students. So it took time, and it took a lot of outside expertise to help them develop the structure, the course descriptions, and the syllabi, and also the resources, books and materials that were needed, and because many of them were outdated. And that is something that we had partnered with a US-based institutions that helped us with that curriculum development, like Jefferson College. So the other lesson was that faculty preparation also takes a long time. It can't be just done in several weeks of mentorship. It takes long-term support. Many faculty do not have neonatal experience, but they have midwifery experience. They have other foundations to work with. So assessment of the faculty that are designated to teach is important. What are their strengths? What are their areas in which they need mentorship? And so we also included preceptors from the clinical, as Dr. Puma was stating, and that was a decision that we feel was a great addition, because the preceptors were able to give clinical experiences and also help with the mentorship programs and the hands-on programs. hands-on care. Okay, from the emerging lessons, we can go to the recommendations. And these are not all encompassing at all, but it's an attempt to look at, well, what we've learned and what we can say in terms of recommending this work in the future. And also, as we go along, there'll be more recommendations, I'm sure. But as you've heard, that time needs to be invested in political commitment. If there is a part of the decision makers who are not buying into the program, they can slow down the process, and it can take months until that decision making is there's consensus on it. So there needs to be that national commitment, and it makes it much easier to move forward on decision making and the task of curriculum development and faculty preparation. It includes in these national committees of decision makers, they analyze country context, the existing health services, the resources, the clinical areas for students that could be used, and they developed different options along the continuum in terms of community-based nursing care and primary health care, and then referral. So analysis of the faculty was really important because we wanted to work on their strengths and then build on their needed capacity to be able to teach competency-based with standards and also state-of-the-art. Advocacy with the government and with the Ministry of Health is also very important because staff is needed, the numbers of staff. WHO has talked about supporting the number of staff planning that is adequate for these units, baby care units, and also the resources for education and clinical supplies and training activities. If you bring students into a clinical area to train them, if they don't have the supplies and equipment, they're going to learn the practices that are poor, not the practices that they should be learning in order to improve quality of care. And that we've talked a lot about the competencies that are needed. There's a difference in competencies between a diploma program, a certificate program, a bachelor's program, and a master's program. And at each level builds on the foundation of the previous. And so it's important to have those levels of care. Which goes into the next slide, which is, we've talked about the pre-service, in-service, and advanced neonatal, that we have to strengthen all of those levels. If you just go in and start a master's program, but there's not a foundation, and that's all the way from applied pharmacology to pathophysiology to developmental care. If you don't have that foundation, then it's very, very difficult to teach at a higher level. So over the 2 years of working in both countries and working with leaders and faculty and clinicians, we really understand the importance of building on the foundation at each level. Also ensure that there are standards of care and competencies, and we know not all of that's in process right now. We have competencies from COIN, and they're being used, and also from WHO, and WHO is also with the roadmap helping us to develop even descriptions of the levels of care in more detail to help us. We also recommend that there's adequate time for faculty preparation. It's not just the curriculum development and the mentorship and the courses, but they have other teaching responsibilities. They can't do it full time, and so there has to be a plan about how they can mentor, how they can get mentored, and how they can have seminars to continue their education. And to really understand that faculty need both didactic and clinical skills. And we found that faculty are very excited about it. They want to learn it. They want to learn all the details of it. They want to take the tests, the check-ins, and they want to be able to be the most excellent faculty that they can be for the upcoming future students. In addition, the recruitment of neonatal students, the retention of the graduates, the strategies and opportunities for career advancements so we don't lose those graduates that we have so diligently trained. So we need to really work with recruitment and retention. As I said, HR planning for multidisciplinary approaches, not just neonatal, but a team approach and effective staffing skill mix has also become more evident. So in summary, the recommendation is a final recommendation is that we really need to develop the leadership of the nurses within their own categories, but also within the universities and the ministries of health, and along the continuum of care of the services to build competency, accountability, and to establish relationships and collaboration to sustain the education efforts. The last slide is, where do we go from here? These may not be all the recommendations, but it's a start. The emerging lessons, it's a start. So if we move ahead, the question is, can we move ahead with a community of practice from what we've started with this webinar? Can we find ways of continuing sharing experience, ways to support those institutions that are developing competencies and standards of care? There are learning networks and collaboration with universities, et cetera, that can help us. And then where are the voices of nurses and parents, as Carol Kenner had talked about in promoting quality of care? And the area of research we haven't talked about at all, but after several years of training of neonatal nurses, what impact do they have on neonatal mortality? Rights-based approaches for inclusion of parents, safety is becoming more important, developmental care, and we haven't looked at that in terms of those points impacting what we do. And then we're finding, as Sue said today, that we have innovative country approaches. And it's not a cookie cutter, but there are different options based on national need. And these need to be shared. And so we've shared some with you today, but there are many more that we could learn from. So as we move forward, we should think of teaming and promoting the leadership in this field. Thank you very much.
Thank you. Thank you for that thorough overview of some of the lessons we've learned and some potential ways forward. We now have some time, thanks to the efficiency of our speakers, who were crystal clear. We have some time for Q&A, and I'll come back to our presenters, and I encourage you all to discuss topics that you're also interested in. We also have a couple of presenters from last week. We have Dr. Kenner on the line from COIN, the CEO of COIN, and I believe we also have Dr. Ornella Lincetto, who leads neonatal efforts at WHO. So we may call upon you for the appropriate question. The first question, maybe for Professor Samai. The question is, what can be done to train enough neonatal nurses to respond to saving neonatal lives in need? How can we take this to scale? Is it Is it a matter of only having neonatal nurses in these special baby care units that you showed? Is it having a mix of staff? What's your perspective in Sierra Leone on this question? Over.
Thank you very much. I think that's one of the reasons why we decided not to go purely neonatal at the level of the bachelors. So we thought we should have a mixed approach where at that level where we are not training specialists, we have people with mixed skills, not just neonatal nursing, but pediatric nursing. Because if we look after the neonates and then they go beyond that and they get to the pediatric age, and that level is not the nursing care is not up to speed, then there will be no work done. The indicators will still look bad. So we believe we should have a mix of people at a level, and once they pass the bachelor's level, then they can now begin to specialize. But notwithstanding, I think to scale this forward, what really we need is a support in terms of trainers and also support in terms of expansion of our skills lab, and also even support in terms of students. But I am very hopeful with the assistance we are having with from Project Hope. I'm hopeful that we'll be able to scale up over time, and then I'm also convinced that with the current new direction leadership government, for which the presidential flagship program is human capacity development, the government also will be able to invest into this. Thank you.
Thank you, Professor Samai. Yeah, so I think, and I'll let others chime in who would like to. I think what we're saying with this advanced neonatal nursing education is it's a mixed model, as you say. We need these specially trained nurses to lead these units that are being established to drive down newborn mortality. Without them, we won't reach the SDG that you showed on your slide of 12 deaths in newborns per 1,000 live births by 2030. That's the SDG, and that is somewhat of a driver for countries to take this step. So what's the right mixture for a given country, I think, has to be determined at the country level. Sue Prulich also mentioned the importance of bringing physicians along with this, whether they're general medical officers or pediatricians, and ideally we would have neonatologists also trained, but as we well know, there's some countries with no neonatologists, and I can tell you, Malawi, I met the one neonatologist. They're going to take time to train, and of course, retention is also a major concern. Does anyone else want to comment on the how do we train enough neonatal nurses? If not, we can move on to the second question, which is around the major leading causes of neonatal mortality in sub-Saharan Africa. And I wonder, Sue, you've been working in this area. We could also ask WHO. I know this is a priority of theirs. One of the things I've learned is there's often a mixture of issues, prematurity combined with hypoxia and sepsis and other complications, which makes neonatal mortality not as straightforward as other forms of mortality in older children and adults. Sue, would you like to comment on that?
I think if you look at statistics across Africa.
Can you speak up a little bit, Sue?
Oh, sorry. Can you hear me now?
Yeah, we hear you now. Thank you.
Oh, sorry. I had to turn my speaker on. If you look at mortality across Africa, I think the three prime ones of being premature, asphyxia, and infection are pretty common. And I think that's identified as, hope Dr. Arnell will speak into that. But then what we don't know is what happens a lot of times to these babies once they hit the neonatal units. You know, once they get to the neonatal units, there's a lack of education on exactly how to move forward with these babies and how to help them thrive and survive. We may be able to resuscitate them, but then when we get them, and so their diagnosis at the time of admission is usually their diagnosis that they die from. So we need some really good statistics and data collection surrounding that for sure. And I'll give over to Dr. Arnella.
Ornella, are you there? If not, maybe we can come back to you if it's taking you time to get on. There's a third question about lactation support. If you could share any experiences, challenges relating to providing skilled lactation support for the neonatal care population. And maybe you could present that in the context of this topic, neonatal nursing education. How is lactation support brought into that training? Sue, would you like to comment, or Carol from COIN?
Go ahead, please. Okay, sorry, I was waiting. We don't have an actual course for it in Rwanda. We address it mostly when we're in the clinical setting, and this is a cultural thing, which we don't necessarily always see in the United States. But there is a culture. You have to look at each country's cultural thing. We have a thing in Rwanda where the mothers are hesitant to start with their breast milk at first. They would prefer to wait for whatever reason. So in whatever context you're in, you need to look at the cultural part of that. But then we also really need to push to starting early when you have a premature baby, to start early to start searching for the milk, because I think a lot of them will wait, and because they've had C-sections or whatever reason. And as we know, the longer you wait, the harder it is to establish the milk. So as in the context of teaching, we do it in our clinical area, and talk about the hormones when they're the highest and the best for lactation. That's all of that stuff. But I think lactation would be a great thing to add as a classroom part of the neonatal programs, because it's one of the missed opportunities.
Thank you. There's a further question about how's it been possible to change pre-service curricula to emphasize skills development and content knowledge. So just as we said, we need a mixed staffing model. So current nurse midwives, or whatever pre-service cadre we're talking about, how can we advance skills development in them? I believe that's some of what Professor Samai was referring to. Professor Samai, any further comment on that? On strengthening the other pre-service content to add more neonatal nursing skills?
Well, I think that is in progress already. We've worked on the BSN curriculum, and a lot of neonatal components has been added. I think what we need to do now is to also look at the MBCHB or MBBS curriculum to see the content of the neonatal component in their pediatric program. So see how we can also strengthen that. But by and large, I think is still work in progress.
Right, and doing those in parallel. Thank you. There was a comment from one of the listeners that the University of Pretoria has a post-basic qualification in neonatal nursing science. Professor Samai, while you're on the line, there's a question for Sierra Leone specifically, whether, I know you considered a lot, and on that slide you talk about all the deliberations, but I think there was much more discussion than you had a chance to go into. And did you consider career development of nurses with a post-basic certificate in neonatal nursing? That's one of the questions from our listeners. Over.
I think the whole career pathway for nurses have been looked at. So whatever we do now in terms of training will have to align to their career pathway. So even before now, for you to be a midwife, you have to do SRN. You have to be a registered nurse for you to enroll into the midwifery program. That has been changed. As I speak, we are now almost at the end of concluding the direct enrollment into midwifery. So you don't really need to be an RN to do a midwifery program, for instance. So we've looked at the whole career pathway for nurses, and whatever program or training program that we are developing or that we have developed will have to align. And I want to assure the audience that the training aligns well with the career path for nurses in Sierra Leone.
Thank you for that. There was another question about examples of neglected topics in pre-service education. Maybe we could ask one of our nursing educators, Sue or Carolyn or Alemas. Are there any? I know you've been working on this post-basic program, but in those discussions, have neglected topics come up on the pre-service side? Over.
This is Carol and Carol Kenner, and as I presented last week, I think one of the things that we've noticed on the pre-service side is most of the focus is still on maternal issues, and well, it should be, and more of the healthy newborn. And so we've been trying to shift, just as we were talking about the skills and the pre-service skills that are necessary, like in Sierra Leone, that we need to also begin to emphasize the premature baby, the small and sick baby, and that's not done right now.
Any other additions? Thanks, Carol. That's very helpful. Any other additions from other participants on gaps? Go ahead.
This is Carolyn Kruger. I was going to mention other gaps are just the developmental care of small babies and newborns. Usually is not in their curriculum. We found another gap of family-led care involving parents, involving fathers, especially in kangaroo mother care units. And then the whole process of preparing parents for the community experience and follow-up care in the community. These small babies, once they're discharged, there's very little follow-up with them and support in the community unless they have mother care groups or community health workers that can make home visits to the family that has just been discharged with a premature baby. And so those topics were really not a part of the pre-service. Go ahead.
Thanks, Carolyn. Others?
So this is Sue. I agree with
Contacts are from the side of outside the retreat for most of this. From
is someone speaking? Yeah, I agree with Carol that pre-service so far, and it's still pretty common to be more focused on maternity, which is fine, is great. We need our mamas, and the immediate, first 24 hours or so. What we lose is we don't have much information on if they survive that first 7 days, on how we can, keep them growing well and keep them moving. And so I think we're working on that. I think Carolyn and Carol did it very well. I would say, though, that if you're developing programs, to be very cognizant of trying to find people that have had neonatal experience to join the program, if they're going to be students, because it's really hard if you've not been exposed to neonates and the things that they do, or been in a neonatal unit. It's really hard, especially at a master's level, to start at that point. Like I think Malawi's gotten it right. They said, we need to go back and look at the bachelor's, and then get a strong grounded neonatal, and then move to the master's. What we've, sometimes find, we have a 2-year requirement of working in a neonatal unit, but it's not necessarily enforced. And so I feel those students sometimes are at a loss or at a deficit before they even start, because they're coming up with terms and activities that they are completely new to them. So that I would think people would need to really think about that, especially if you're starting at the MSN level.
Thanks, Sue. The next question, I think I'll come back to Professor Samai and Sierra Leone's, considerable deliberation about the linkage between pediatric nursing and neonatal nursing. The question is, does it mean that the nurses spearheading neonatal nursing in these two countries have a pediatric nursing background? Professor Samai, could you comment on Sierra Leone's discussion around this topic? I know it was.
Say, go over it again. Go over it again.
The question is, does it mean that the nurses spearheading neonatal nursing also have a pediatric nursing background? And you have those two options, right? In Sierra Leone, to pursue a pediatric track or a neonatal track, but there's a common basic training to both of those tracks. Is that not the case? Over.
Yeah. I think at the undergraduate level, they have to benefit from both tracks. They will only go specifically into pediatric proper or neonatal nursing proper at the postgraduate level. But at undergraduate, it's a mixture of the two, because as I said earlier, we don't have the luxury of the human resource to begin to go into specific discipline at undergraduate level. So we thought at undergraduates, we should expose them to both disciplines to a larger extent, so that they will be able to work either in pediatric or neonatal facilities. And then once you go above that, once you specialize, then you can now work in one of the disciplines. Over.
Thank you, Dr. Samai. The other is a comment just about the WHO roadmap for improving neonatal nurse training, and this participant is just excited by the support and advocacy from WHO that'll give support to their professional association for standalone post-basic neonatal training in South Africa. So thank you for that comment. We're approaching our time to close, but there have been a couple of questions about how can we further leverage this platform that we've had these past couple of sessions to further assist with enhancing neonatal education in low and middle income countries. And so I guess I'll throw it out there for any of our participants to pitch in. You know, what next? How can we use this platform? Obviously, the real work happens at the country level. We need the technical people, but we also need the decision makers and leaders to endorse this as a part of the pathway to achieving the SDGs. But any thoughts on how we can keep this platform going to further share lessons? Obviously, we have COIN, the Council of International Neonatal Nurses, as a very valuable partner, and WHO is active in this. USAID has showed much leadership in this over the years, and of course we have ourselves as partners implementing NGOs, working with ministries of health and training institutions. But as we see, there's a lot of different approaches around the continent and beyond, and we can learn from other parts of the world, Asia, Europe, and elsewhere, how they're approaching this. But any suggestions on how we can keep this going? Carolyn, you mentioned some of this in your closing remarks.
Yeah, I really threw out some ideas about what we could do with networking, with sharing experiences, with advocacy for, you know, building competencies and standards. It can be shared rather than repeating it and developing it from scratch many times. And just with new concepts that are coming up, like family-led care and those technical areas can also be part of it. It would be very beneficial, I think. It would have been beneficial to us when we started 2 years ago. And then we collaborated with COIN and other organizations, and that's been very, very helpful. So Jefferson College, for instance, here, and it's been very, very helpful. So I think the collaboration, the networking is really important to you know, to forward this whole effort. But how to do it, that's what the question is, and what platform to use.
Thanks, Carolyn. Any others? There is strong interest in keeping this alive, and obviously we have many dedicated listeners who want to see this specialty nursing further emphasized. And one listener here, even going beyond specialization in neonates and talking about congenital heart disease, which is a big killer of newborns born with congenital defects. It's the leading killer of kids with congenital anomalies. So and a lot of those are correctable. So there are a lot of really important issues. I think you know, we need to keep our engagement with WHO, and certainly the countries have that connection to keep this going, and we'll give that further thought. And we would love to hear from others. There's a question about recordings, and that will be sent out at a link for both part 1 and part 2. So if your colleagues didn't get a chance to join, or you'd like to share this with others, you'll be free to do so. So on that note, we've reached our time. I really want to thank our excellent presenters this week, but also last week, and thanks to people on our team who made this possible, and we look forward to further engagement as we move this forward. Thank you, and have a great day.
Thank you. Thank you.
Thank you.
Thank you.